Welcome to the Grange Clinic Edit. I'm Mrs. Anoni Harper-Machin, consultant plastic surgeon.
And I'm Miss Parneet Gill, consultant plastic surgeon as well.
And we'd like to do our podcast for you today on skin cancer. May is Skin Cancer Awareness Month, and as we have all just heard on the radio and in the media today, that melanoma skin cancer is at its highest rate ever. And in fact, there were over 20,000 people diagnosed with a melanoma skin cancer in the United Kingdom alone. And that apparently is predicted to go to nearly 30,000 patients by 2040, which is an incredible skin cancer burden on the NHS and also on those patients as well. So we both specialise in skin cancer surgery.
Yep.
And we just wanted to present to you today the commonest sorts of skin cancers.
So there's obviously a range, isn't there? So there's loads of different types of skin cancers, but we're going to talk about two in particular today.
Yeah.
So one is a basal cell carcinoma, also known as the BCC, which is in fact, it's the most common type of skin cancer that tends to present to us in the NHS and privately, actually. And Anoni's going to talk about melanoma, which you've started talking a little bit about it already, but it's one which does need to be taken seriously because it can be one that can spread. It can be life-threatening if not treated. So it is one of those where it's really good to pick it up early and be very vigilant about what to look out for. So hopefully we can give you a few little ideas of what to look out for each type.
So I know you were saying about we need to take melanoma skin cancers seriously, but I know that you have dedicated your career so far to the treatment of basal cell carcinoma, which I think is a skin cancer that is grossly underestimated.
Absolutely. I think it's one of those where even when you get referrals, it's always a case of, it's only a BCC. But actually,
no such thing, hey?
there's no such thing as only a BCC. So, in fact, even those can grow very quickly at times, cause a lot of destructive damage to the surrounding tissue and the specific structures. So it is one of those where traditionally it was known as a rodent ulcer. So some of my older patients don't even really consider it as a cancer. They just think, it's just a bit of a sore. But actually, with basal cell BCCs, they do have to be taken seriously as well, because otherwise they do get ignored for years and years.
And then can be quite destructive, really.
Yeah, because then they can be damaging structures, but also they bleed, they're painful. And, even with BCCs, like the sooner you get it sorted, the better.
Yeah, absolutely. And I think GPs and other caregivers will call it a rodent ulcer because, like a little rodent, it nibbles away at the ordinary structures of your often face. It's most common on the head.
You can get it anywhere on your body, but the common areas are face, arms, legs. Basically, sun exposed areas tend to be
So over a whole lifetime, and so. Generally speaking, it's the older generations that will suffer with basal cell carcinomas, but I
get loads of younger patients as well. Yeah. And I suspect because people are more aware of skin cancers now, and, especially if it's on your face, with younger patients, they are more bothered about, something's not quite healing, it's not bleeding. So they will go to their doctor or seek medical attention for it a lot sooner than, say, our older patients who would just put up with certain things on their face and not think it's important enough to get any sort of, advice.
Or anything or any advice. So what are we looking out for then? Okay. What does a basal cell carcinoma look like?
So I guess the main thing is that it can look like many different things. So I'll show you a very sort of common presentation. So there's different kinds of basal cell carcinomas. You can get nodular ones, which are a little bit more lumpy, can look like a bit of a spot. You can get infiltrative basal cell carcinomas, which look more like a scar or an area of crusting.
Now, I've had patients that have commonly come to me and said, oh no, that's nothing to worry about, it's where my glasses sit.
But it's not.
Actually, it's not.
So they can look really normal.
Yeah.
Often patients say, it's just a spot, or it's a little bit of crusting, a bit of dry skin. And actually, it's when it doesn't resolve and you get continuous sort of breakdown of the tissue or crusting or bleeding or something that's not quite going away is getting worse and worse. Those are the kind of signs that you need to pick up on, really, when you shouldn't just accept it as just a spot, because that may very well be a basal cell carcinoma.
Yeah.
So the commonest type that I see really is either nodular or infiltrative. So I've got a good picture of a nodular basal cell carcinoma. So very typically, they're often quite raised, can look like a bit of a spot or a cystic type lesion. They have this what we call pearly appearance, where it looks a bit shiny around the edges. They can have vessels, so blood vessels, and when we look at it with a special thing called a dermatoscope, we call it arborizing vessels. So they have very thin sort of blood vessels on the surface. So they can be a bit indurated at times. The centre of it can have a little scab in it, or a bit of keratin, well, not keratin, but a little bit of gunk in the middle of it. So, they can just look like little scabby things that are not healing. Yeah. But this is a very common type of sort of very traditional BCC.
Of a
but obviously it can look very different to this as well. But this is the sort of commonest. But, if you look at that, if you weren't a medic, you may think that's just a bit of a spot that you've picked, isn't it? And a lot of patients, a lot of older patients will think that
hair, or anything really. They're great masqueraders of things, other things. So how are you treating that? What do you do when somebody comes and they do get referred for this, or from their GP? What treatment can somebody have for their BCC?
So the important thing is getting the diagnosis first of all, because sometimes things look like BCCs, but actually they come back as benign lesions, so they're not always a BCC. So the first thing you would do is get a biopsy, and biopsies can either be cutting the whole thing out with a bit of margin around it, or taking just a little sample of it just to confirm that it definitely is a BCC. Then once you have the diagnosis, you can either go down the conventional surgery route, where we, in plastic surgery especially, we take a 3 to 4 millimeter margin around the BCC as per BAD guidelines. And the point of doing that is to get a safety cuff to try and make sure that we've got the whole thing out in one go. Yeah. And then once that's cut out, we send it off. It's normally done under local anaesthetic, fairly straightforward. And then we fix it up on the same day as well, whether that means just stitching it or doing something a bit more complicated like a skin graft or a flap. Now, my current job, my main job in the NHS is actually a Mohs surgeon. So that's a slightly different technique of removing these type of BCCs. And with those, what we do is we cut it out with a little bit of a margin of normal skin around it, and we test it on the day of the procedure. So the patient normally stays in with us. It's all, again, done under local anaesthetic, but a little bit of waiting around, and we can check to see if we've got the margins clear. And if we haven't, it's okay. We could take the patient back to theatre, take a little bit more, and we keep going till it's clear. And then we fix it up on the same day as well. Yeah. And that's really good.
And I want to make a differentiation between, so Mohs surgery, it's spelled MOH''S, and it is the name of a surgeon who developed the technique.
Frederick Mohs. He was actually a medical student when he was a very clever chap. Yeah.
And I have to, as a plastic surgeon, I do deal with basal cell carcinomas quite a lot. My version of surgery is the standard excisional surgery. And I will send patients to Ms. Gill. So if I think that the borders are a bit diffuse, it's near a very anatomically sensitive site where if I'm wanting to do a reconstruction or think a reconstruction is going to be necessary, I want to know that that tumour is clear and got rid of before leaving any more scarring on a face or that type of thing. So at that point, I will offer a patient, I'll say, the best thing for you is going to be Mohs micrographic surgery. I will do the tiny biopsy and I will send you to my colleague. If it's something like this and I'm pretty sure like of the diagnosis or whatever, then I can offer standard excisional surgery, which by and large for most people is
absolutely fine.
Absolutely fine. Yeah. But whenever I see, so that's what, as a plastic surgeon, that's where my differential lies between who I operate on and who I will send for specialist kind of basal cell carcinoma surgery.
I mean, there's certain sort of, tick boxes that you sort of can sort of say, okay, that person definitely needs Mohs rather than conventional. So I think you've named some of that already. So diffuse edges, difficult to manage. And when you know you're going to have a difficult reconstruction, you have to be sure that your margins are clear and that, the worst thing is, do a really fancy reconstruction and the margins come back incomplete, isn't it? So
it's a horrible feeling.
Yeah. So obviously, if we can avoid that from the get-go, then that's a gold standard. But also, patients who have had reconstructions done and it was found to be incomplete. So we do get those patients referred referred to us for formal excision using Mohs before any further reconstruction. And as well as, like you said, the anatomical areas such as around the eyes, nose, mouth, lips. So in those areas, we don't really want to waste any skin or tissue if we can avoid it, because it's very sensitive and difficult to reconstruct. So, we try and keep the defect as small as possible, and Mohs can sometimes allow us to do that.
Yeah.
So, yeah.
But I would say the vast majority of basal cell carcinomas are relatively small, relatively well defined, and most are suitable for standard excisional surgery.
Absolutely.
It would be, I know you have a heavy patient population, but we take from a catchment area of, I think it's 8 million people now in Cheshire and Merseyside for plastic surgery. So we do see a lot of the more complex tumours, but by and large, it's like
We're
this
quite
one.
niche, aren't we?
Yeah. And so yeah. But we treat these in the NHS, we treat them in the private sector, and it is a curable disease, with surgery. Are there any other treatment modalities for basal cell carcinoma, for example? Yeah.
So depending on what kind of BCC it is, if it's a superficial BCC or that's a very thin type of BCC, these can be treated with topical creams or curating them off or freezing them sometimes. Often the dermatology team can do that. If it's more nodular or infiltrative BCCs in patients who don't want to have surgery, then we also offer something called laser CO2 PDT. So it's a very niche type of treatment that's offered. And it is after the patients have been discussed in the MDT meeting, and they're definitely not surgical candidates because surgery is the gold standard.
Yeah.
However, it's a really good alternative for those patients because it allows I do this in my service, to use a CO2 laser to basically burn away the BCC after injecting it with local anesthetic. So it's done with the patient awake. And then once I know that I've got through the actual lesion itself, then we apply some light sensitive cream on it called Metfix, and then we put a dressing on it for 2.5 hours, and then after that we undertake photodynamic therapy. And then what that does is it allows the area to just heal by secondary intention. There's no stitches, there's no grafts, no flaps, it's all secondary intention healing. But because we are burning it away, it's basically a controlled burn with the CO2 laser. We can't be absolutely sure that we've got every single bit of the margin. So we do go a bit wider to try and catch it. But in order to maximize that cure rate, I do 2 sessions of that treatment. So by the second session, it's a lot quicker to do. And it just gives that a little bit more of a belts and braces approach to try and get that cure rate as high as possible. And actually, our 5-year recurrence rate is sort of 3.5%, which is, which is comparable to conventional surgery. So, but it's only in the certain patients that aren't suitable surgical candidates. And then also there's radiotherapy, but I'll be honest, I don't really tend to send patients for radiotherapy now. If they're not suitable for surgery, they'll be offered laser.
Yeah.
And then radiotherapy is usually if, we've done the surgery and bone was involved, or, there's certain patients that would benefit from adjuvant post-operative radiotherapy.
Then they get sent.
Yeah, it's not very often though.
No, that would be pretty unusual for basal cell carcinoma, isn't it? So yeah. Okay. And so basically it is a side effect of chronic sun exposure over a whole lifetime. Looking out for is a relapsing remitting lesion that comes back again, maybe goes, scabs, sometimes bleeds, and has this sort of nodular or lumpy appearance. Sometimes it looks like a little flat scar, sometimes like a little pink patch. But if you have something that's not going away and not healing, then it should be checked over by usually your general practitioner, or you can book in to see plastic surgeon or whatever in the private sector and have it looked at. So yeah.
Yep, great. Okay, great. So we've talked about basal cell carcinomas, which are the commonest cancers that present to us. But there's also melanoma. We sort of touched on it in the introduction. So you obviously see a lot of melanoma patients, Zanoni, but how is melanoma different to, say, basal cell carcinomas?
So melanoma is a skin cancer of the pigment cells, so the cells that make your freckles, your moles, and your skin go tan in the sun. So melanin production is important for sun protection in human beings, and that's how we resist UV radiation in nature. But whenever those cells change, they can change into melanoma skin cancer. Most melanomas will develop out of areas where there's not necessarily been a mark or a freckle before. And then there are melanomas that will develop from a mole or a mark that has been there for a long period of time. So really and truly, any brown or what I call pigmented lesion or mole that has started to change or has just appeared.
So what kind of changes specifically would you be sort of looking at then?
Should be checked out. And that is an area that appears where you've never had something before. Mm-hmm. And usually melanoma skin cancer has an irregular or more jaggedy kind of border. Mm-hmm. Usually it has areas of darker and lighter pigmentation. It's not a regular or homogeneous pigment. And it can be larger. Often melanomas tend to be on the larger side, so around about 1 centimetre.
Okay, so it's pretty big.
Yeah, they do get big. And I have an image here of exactly what I've just described to you. So you can see in this image that that likely this area is where things kind of started off. And possibly that person had a mole or a freckle in that area, but you can see this irregular lesion, jaggedy edge lesion sort of coming out from maybe where the main area was. And the pigment is very different throughout. That area is very dark. There's another very dark area down here.
It just looks really patchy, doesn't it?
It just looks patchy.
Really patchy.
Yeah. And again, when you look at it under the dermatoscope, so the magnifying light, you see this variegated pigment throughout. Sometimes some of the little blood vessels, sometimes what they call a veiling of pigment within the skin. So that's just the semantics of looking at something under a dermatoscope. But if you're seeing this sort of image on your body somewhere, then you need to get that checked out. And sometimes people can have pretty irregular moles, they can...
Or even like the warty things, isn't it? Seborrheic keratosis, because a lot of patients have a lot of those and worry that they're melanoma.
Yeah.
But actually they do look very different when you look at them closely, don't they?
Yeah.
But I guess to a patient, a brown patch is a brown patch, isn't it?
A brown patch. But... it's hard to tell from this image a little bit, and that's why it is good in the physicality of things. But it does look a little lumpy, this one.
Yeah.
And seborrheic keratoses, they almost look like little plaques that you could pick off.
It's got that waxy appearance, isn't it?
They're waxy, almost like a little brain.
Yeah,
it's like a little
cribriform
brain sitting on your skin. Yeah. So if it looks like that, it's possibly all right.
Yeah.
If it's kind of like lumpy like this but doesn't look like you could pick it off, then it's possibly something a bit more to worry about. Regardless, to be honest, you should have if you think it's changing, you think it's pigmented, it should probably be checked out.
Because a lot of the time when we do remove them, they come back as dysplastic nevi or other changing moles, basically, not necessarily melanoma yet.
And I myself have had a dysplastic nevus removed from the back of my thigh.
Yeah, so they're quite common, aren't they?
They are very common.
They're more common than you think.
And it was my husband said, you need to have that checked out. I tried to look at the back of my own thigh.
It's hard to if you can't see.
Didn't see it, and then left it. And then a few months later, he was like, no, really, you should go and have that off.
And he's an orthopod.
And he's an orthopedic surgeon, yeah. So it happens. And like in hard to look at areas, if somebody is telling you that they think there's something changing on the back of your leg or on your back, then do listen to them and go and get it checked out. And we talk about the ugly duckling. Mm-hmm. So I have a few moles and freckles and bits and pieces, but it's the one that stands out.
Yeah, the one that catches your eye.
The one that catches your eye, catches your family's eye.
Yes,
and my father-in-law won't mind me talking about this because he tells everybody. But he's had a melanoma skin cancer on his face.
Right.
And he is of the generation where people went out suntan, sunburned, hot holidays, that type of thing. And actually he asked me to look at something that he had only noticed when he shaved his beard to a goatee. Mm-hmm. and said, I think this has changed, or it seems to, and I've just noticed it now, I've shaved to a goatee.
Yeah.
What do you think? And it was a melanoma.
Yeah.
So it is very common. My family has been touched by it. I know that most people will know somebody that's maybe had a melanoma skin cancer.
Yeah.
And caught early is curable. But left, it is a skin cancer that, unlike basal cell carcinoma, can spread elsewhere in the body. And that is my number one life goal, is to sort of get melanoma before we have to do any of the more advanced kind of surgical stuff to get rid of it. And then also there are now neuroimmunotherapies that we are treating patients with, that maybe have had their melanoma spread beyond the skin. And so the treatment options now for melanoma are vast in comparison.
So if someone came with a changing mole, let's say, what would you do first then?
So you have a small excisional biopsy first. And by that, I mean that the whole pigmented lesion is removed and should be removed. And often the dermatologists will refer me larger lesions, that type of thing, in order for that to happen.
Yeah.
All right. And that gives a diagnosis. So if you then have a diagnosis of melanoma skin cancer, then you are, depending on what you need doing, you're probably coming to see somebody like me.
A specialist melanoma surgeon. Because it does depend on the thickness as well, isn't it? With melanoma, it's not just the margins, it's actually
how thick the tumour is. And so whenever you've had a biopsy, it gives me a whole lot of information on tumour thickness and several other sort of risk parameters that then stratifies you and your melanoma into a certain treatment pathway.
So they need to have more treatment after the initial biopsy for diagnosis?
Absolutely, yes. So the biopsy gets the diagnosis and gets me that information.
Yeah.
And then I can talk to that patient about how we would treat their melanoma. Usually that is a wide excision of the skin around the scar of the biopsy. And people say, well, it's gone, it's been biopsied, why do you need to take more? And I use the analogy of, it's like raking up leaves into a bonfire. So like you do a fire break by raking those leaves up, if I remove a margin around that scar, if there has been any little cells that have already broken off into the periphery, I'm raking those up, I'm mopping those up. And so
it's
that
a safety
gets rid
thing,
of
isn't
it
it?
out of the skin.
Yeah, it's to minimise the risk of recurrence, but to actually fully treat the initial
Full
disease as
well.
Okay.
And so by and large, that is curative for most of our thinner melanomas.
And they get followed up as well, don't they? So,
caught early, you have your biopsy, you have your wide excision, and generally speaking, that's it for most people.
Yep. But what if it's not, though? What if there's more to it? So you obviously get a lot of complex patients because we're a tertiary referral centre. But if we sort of just keep it simple, but just so that people have ideas of what could
So if your melanoma is thicker than 1 millimetre, basically that's the general gist now.
Yeah.
So if the tumour thickness in the skin is 1 millimetre or greater, then often those patients are offered a lymph node biopsy test as well. And what that does is it's a surgical test that gives a snapshot of what's happening in your body, in your lymph nodes at the moment, to see if the melanoma has spread to the lymph nodes yet or not, as the case may be. And it gives us an awful lot more information about that patient's melanoma, and then opens up treatment pathways like much earlier than ever we could have done it before.
So information is power, basically,
absolutely,
isn't it?
It is. And so it allows for patients then to make informed choices as to whether they want to have immunotherapy, so the drug therapies that we now have for melanoma.
There's loads of exciting stuff happening with that at the moment, isn't there? So
it's changed even this month.
Like
what we can offer and what we do for certain types of melanoma and certain patients. But yes, essentially it is kind of the gateway to kind of the drug therapies, maybe more surgical therapy, that type of thing. And our lovely pathologists can pick up melanoma cells and lymph nodes now down to like 1 or 2 cells.
Yeah.
You know, so they pick up now spread of melanoma incredibly early. And it is a surgical test. It is done at the time of your wide excision, so everything is done together. And then I do the patient's reconstruction as well at the same time.
Yeah.
And it is essentially you're injecting a dye at the time of surgery to sort of act as a proxy of a cell of melanoma. So the dye flows through the lymphatics and settles in the lymph nodes that if we're to find melanoma, that's the most likely place.
It's like a map, isn't it?
You map your lymphatics out and the lymph node. And I always say to patients, just because it shines up in a lymph node doesn't mean there's melanoma there.
Yeah.
I can't tell with the naked eye. I just need to take the lymph node out and it gets sent off to the lab to be tested.
Yeah.
And then once everything is healed up, then we have the results and we can then plan for further and ongoing treatment. So it is pretty complicated.
It's complicated, but I think you've done a good job of just explaining the basics just so that you have a bit of an idea. Yeah. I guess the point is picking up things early as possible. So what I would say is if you're worried, get it checked out.
Yeah.
You know, if it's bleeding, get it checked out.
And I'll be honest, you know, if you are worried about something, if you have gone back to the GP more than once with a mole, you know, and maybe not had the answers that you want, do persist, because melanoma happens in young people. Yeah. And I do have a very small but significant cohort of children that I treat for melanoma.
Right, gosh.
And you know, and that is recognizing that this can be a problem even in much younger age groups. Pregnant ladies. Yeah. So melanoma, because you are by virtue, you're a little immunosuppressed when you're pregnant. Moles can change more rapidly in pregnancy and after childbirth. And so those need to be taken very seriously as well. And so unusual presentations of melanoma and stuff can be a problem. So if you're worried and you're not necessarily getting the answers you need, persist. Show your GP this podcast, because it does happen in younger people, and it does need to be taken very seriously. So yeah.
I think people do pay more attention as well now, because I'm sure it's the same with you. I get asked so many times every week, can you have a quick look at this?
Oh, and
what do you think about this?
I'm like,
can you have a quick look at this? And obviously, you know, we're trained in plastic, so it's easier for us to sort of say, okay, actually that looks okay, that was probably okay, that's a wart, that's this and that, and you know, or actually you probably should see your GP just to get that referred, just to make sure it's nothing untoward, you know. But it's just, I think people are more aware of their bodies now and of lesions and things. So I do find that, you know, I don't know, maybe we're really approachable. I don't know. But I mean, I know for a fact that I get asked every week, at least by one person, can you have a look at this? What do you think? So, you know, if you're not sure, just ask.
Yeah.
Yeah.
And if you're not sure if something's changing, most people have a smartphone these days.
Yes.
And so I say often to my current melanoma patients, you know, if you're worried about something, take a picture of it, have a folder in your phone with skin on it, and just save the photograph in there. And then next month, take another photograph of it.
That's a good idea.
You know, it just is a way of easily kind of mapping these areas, because the zoom function and the pixels on the smartphones are so good now that you can zoom right in and you can see that lesion, and a good clear photograph can monitor your skin for you without needing an app that you pay for or anything like that.
No, a good photo. But, you know, ideally, if you can put a little measurement thing next to it, that's like super, you know.
Helpful.
But don't be too obsessed by it either. Yeah. You know, it's one of those where often it's just for more reassurance. So, you know, I get a lot of patients who have got loads of moles on their back and they just can't see stuff. So you can get someone to take a photo and, you know, just for their peace of mind, they can see nothing's changed or nothing's looking more obvious. So it's just sort of practical things that you can do, you know, just at home without having to go to see a doctor, that can maybe be a bit more reassuring.
Yeah, for if you do have a lot of moles or freckles on your back or somewhere, just take a smartphone shot of it, and if you're worried about something, then you have a little bit more ammunition to go to your GP with and say, look, it looked like this, 3 or 4 months ago, and now it looks like this,
changed.
and I'm worried. Yeah. So yeah,
that's a good idea.
that's what I advise people to do. So yeah. So melanoma in a nutshell: don't ignore changing pigmented lesions. Look for they classically call it the ABC, that you're looking for asymmetry of the borders.
And you can get them under nails as well.
The colour,
you?
yes.
That's the other one that sort of pops up every so often.
So anything that, you is not growing out or going away, and often the pigment kind of bleeds into the skin of the fold.
Yeah.
So that's the number one thing I'm looking for if somebody has referred me a pigmented nail lesion.
Yeah.
If there's just a little streak of pigment in the nail, that's usually
it's often just a
normal variant.
A trauma or melanosis. It's very common in Asians. You get sort of brown streaks, which is melanosis, but not melanoma.
But not melanoma.
Yeah.
So if your pigment is, in the nail, but it's also coming into the skin at the bottom or the fold of the nail, then that's a little more concerning and would kind of warrant a biopsy.
Yeah.
But under the nail melanoma is pretty rare.
Yeah.
But it is something, that if you have that, then get it seen to, basically. And again, melanoma is curable.
Yeah.
And curable with surgery, usually in the first instance, but only if it's caught early.
Early and treated
early.
In good time, isn't it? So,
yeah.
Okay.
Yeah.
Great. Good.
So that's melanoma in a nutshell. But I just wanted to touch on, being as it's the bank holiday weekend and we're going to be having a heat wave, how to protect yourself in the sun. So I know you're more blessed with melanin than I am.
I still use sunblock though.
There you go.
Even it's anti-aging, protective against skin cancer, good for, pigmentation. So, all of the other stuff as well. And the skin cancer benefit is obvious.
Yeah.
But usually I get patients, using the SPF a bit more regularly by selling the other side of the benefits as well.
Absolutely.
So absolutely really important for using a high factor sunblock regularly. It's more that you're topping it up regularly. And even on days which are cloudy, you are still going to get exposed to UVA, UVB. So, with my skin cancer patients especially, but even, just for your general skin health, I would say you still need to wear sunblock even when it's a cloudy day. So a lot of patients say, I don't really sunbathe. I'm not a sun worshipper. But majority of the patients that present with BCCs, melanomas, aren't always necessarily sun worshippers, but it's that sort of continuous exposure to the sun over years with, damage to the skin as a cumulative, thing. It's not always just a single sunburn episode that causes it,
Yeah.
So it's important to keep that protection going regularly.
And people ask me, what sunscreen do I recommend? And I recommend one that you'll wear.
Yeah.
Because if you're happy to put it on and wear it, then that's the sunscreen for you. And so go to the supermarket or the high street pharmacy chains, and they often have a selection of sunscreens of
There's
all
so
different
much now.
brands.
I mean, skincare is so popular now. So
and just try a few on in the supermarket, because they're all there in the aisles. And the one that you think that you're going to be putting on your skin and feels comfortable is the one you should buy.
And often the one for the face is different to the one you would use on your body, because the facial SPFs are usually a bit easier to wear. They're not as thick usually. They're a bit lighter. They can be tinted. So there's so many different ones that are out there, and you can pick one that you would like. So I use a tinted one because it helps with pigmentation, as well as, it acts as an additional barrier against direct light as well. So, you can wear it instead of wearing foundation and stuff. So a lot of them are so good now that, majority of patients will just wear exactly.
Yeah.
So there's so many. There's in stick form, spray, cream. There's no excuse really. You can pick whichever one you're going to use and just use it, and keep it, in your pocket, keep it in the car, keep it,
Yeah, my husband used my tinted one skiing and was like, I look like I've been airbrushed. So even the chaps like the little bit of makeup in it and stuff. So yeah. But yeah, SPF is your number one. Don't
forget your ears, don't forget your lips, as well as your face.
and the hairline. So I use a dry sunscreen spray in the hairline and on my nails.
Fab.
And any sort of hard, like ears, dry sunscreen spray, because it's hard to get cream on your ears and it all rubbed in and stuff.
Yeah.
So people don't like to do it, but a little spray on the ears, no problem at all.
Yeah.
So those are all my sun
big hats,
tips.
Sunglasses, sunscreen.
Yeah.
And you can even get, the SPF protection in clothing as well. So certain patients will wear, with tops and different things. So yeah, there's so much out there now. And I guess it's a case of, as long as you're being consistent in what you're doing, you will get some sort of benefit. Better late than never as well. A lot of my patients say, I haven't ever worn it. You can start now, and actually, it's still useful. You don't miss the boat with it, really.
And I'll just, I suppose, bringing things to a close, but like just debunk another myth and say that, I need the sun for vitamin D as well. And yes, you do. But in this country, by and large, everybody is low in vitamin D.
Everyone's on supplements or
so
needs supplements or should be on supplements.
Yeah. And a supermarket vitamin D supplement or multivitamin with vitamin D in it is more than sufficient.
Yeah.
And probably everybody in the United Kingdom should be doing that anyway.
Yeah.
So wearing your sunscreen is neither here nor there.
Yeah.
Because you should probably be supplementing with vitamin D regardless.
Anyway.
Yeah. So because we find we do test the vitamin D levels in our melanoma patients.
And they're always low, aren't
always
they?
Low.
It's not very often that they're
normal. Yeah.
Absolutely.
Unless somebody's already supplementing.
Yeah.
So yes. So don't be worried about needing your vitamin D. Yes, you do need it, but get it elsewhere, not necessarily from the sun.
Yeah. So I hope that's all been very helpful. It's a lot of information, and we only really stuck to BCCs and melanomas. Of course, there are so many other different kinds of skin cancers as well, but these are the ones that are either very common or ones which can turn into something a bit nastier than, if you do nothing about them. So hopefully all of that information was useful. And I guess the bottom line really is, if there's a lesion that you're worried about isn't settling, is bleeding, is growing, is changing colour, get it checked out. So whether that's with your GP or booking in with a plastic surgeon or a dermatologist, it's better to be proactive. So any questions, put it in the chat and we can hopefully answer them for you.
Absolutely. And we'll see you on the Grange Clinic Edit next time.
Bye-bye.
Bye.